So I would alter it a little bit. The surgery is also a little bit different for a fracture patient as compared to a arthritis patient. And it's different in the sense that we might just replace the ball part rather than the ball and socket joint. And I can show you here a couple of the common types so we'll know the difference on how they work. The prime part of the hip is the ball. It's a ball and socket joint, as most of us know. And the way we fix the new ball, which would look like this, it's a little smaller in diameter than most of our existing natural balls, is on a stem like this, placed inside the bone, anchored with or without bone cement, and then, if needed, for arthritis patients, we would always need a socket as well because it's worn just as much as the ball is worn. We'll put that together in this way and we get a nice, smooth, low friction environment. For a fracture patient, we might not need the socket since they have just usually damaged this neck area of their own hip, and we'll just probably turn our attention to it. As far as the dynamics of doing a hip replacement surgery, the key difficulty does not lay at all with the hip. That's pretty much a solved problem. Our metals are such that they will stand up to pretty much indefinite use without fatigue, without fracture, without wear. None of those things seem to happen. Same thing with our acrylic high-density polyethylene sockets. They tend not to break, they tend not to wear. There really is very little difficulty with the actual implant. Our major area of concern is how to anchor these non-living things to our living tissues. And that's the majority of the research and technical advances are coming in that way. There's two basic ways of doing that now, and one is to bond with bone cement, which is a grouting material, very similar to the way we grout tile together. It interdigitates with normal bone in a way that gets a permanent bond. That's been very successful. It's been done since the 1960s. It's safe, it's effective, and it's can give a bond that is immediate. That's very attractive for the patients that we're dealing with. More recently, there's been interest in anchoring hips in other ways because of some of the very late complications. After several years, 10 or more years, sometimes we've seen some problems with that bone cement, that it can, over a long period of time, crumble or come loose. Not commonly, but sometimes. Enough that we've had interest in other ways. Hips, such as this one, have been used and used with a high degree of success. It allows the bone to grow into these rough pores, and they're just the right size so that they mesh perfectly with the type of bone that we have in our hip area. And this type of implant, when it happens, when this interdigitation occurs, is really a permanent bond. It can last indefinitely, and it's been a very, very attractive solution for certain patients. Another type, and so we'll have all three that are really currently available, is this hip, which we call a press fit, where we have major flutes that will allow us to bond directly to bone in a very mechanically sound way. That's also an immediate fixation that does not require much bone response.
What kind of recovery time are we talking about? 6 months?